Hello, everyone. Welcome to the AAG webinar. Please note that this webinar is being recorded for future placement on AAG's website and YouTube channel. All participants are currently muted. Please place your questions and comments in the Q&A box for discussion with the speakers after all presentations are completed. AAG is very pleased to have the financial support of a number of sponsors, and we would like to take some time to recognize them now.
Hello, everyone. Good afternoon. I'm very pleased to welcome you all here today to this third webinar of the AAG's Future Policy Forum, titled Improving the Work Environment for Senior Services Workers. My name is Vivian Lai. I'm the chair of the AAG Futures Policy Forum Initiative. Alberta Association on Gerontology is a member-based organization focused on advocacy of policy for healthy aging and quality of life for older adults. AAG members come from across Alberta. They include older adults, caregivers, care providers, organizations, educators, researchers, policy planner, and students. AAG organized this Future Policy Forum with the objective of raising the public awareness on the need for the transformation of the senior services system. We want to engage the public in the policy discussion and implementation and for improving and transforming the current system. We invite you, we'd like your participation in this discussion and be the change agents and champions for such innovative changes. We are pleased to say that today we have 329 registrants registered for today's session. The Alberta Association on Gerontology acknowledges its presence on the lands of Indigenous people across Alberta. We are committed to ongoing dialogue and shared learning to achieve healthy aging and quality of life for older Albertans. The Futures Policy Forum series are made possible by a number of financial sponsors, which you have just seen on our opening slides. I'm very pleased to introduce Dr. Catherine Chucks, President and CEO of Good Samaritan Society, one of our platinum sponsors, to make a few introductory remarks. Dr. Chucks.
Good morning, Oki, Tansi, hello. Thank you for inviting us here to sponsor this today. I just want to tell you a little bit about Good Samaritans. So we're a very diverse organization. We have many services. We are faith-based, a not-for-profit, and a registered charity. We are in Western Canada, and we provide quality accommodations, health, and community care services and programs to aging individuals in need. We have nearly 75 years of experience providing specialized health and community care services in innovative and caring environments. Our operational effectiveness and our overarching culture of service and care make us a provider of choice for individuals and their families when they're seeking a place to call home. We have over 4,500 employees and nearly 2,500 volunteers who together, in the spirit of compassion, serve over 5,000 residents and clients. We're the largest not-for-profit provider in Alberta, and we're in 21 locations, and also in BC in 8 locations. And we provide safe, comfortable communities, inspiring involvement, where people can experience a sense of caring, belonging, and purpose. We're proud to be a partner in the comprehensive home option of integrated care of the elderly, which we call CHOICE. That's the first program of its kind in Canada. And another way that we're committed to helping people lead more independent lives is through our seniors clinic. Located here in Edmonton at our head office, this clinic helps seniors with complex health issues by providing primary health care or partnering with family physicians. Our clinic is devoted to seniors, and the medical team includes physicians with training and care for seniors, nurses, and advanced training in geriatrics, a pharmacist, and a physiotherapist. We are so pleased to be a sponsor of this AAG initiative. Collectively, together, we can change the future for seniors. And through partnerships with organizations like AAG, we will build a better tomorrow for those we serve. Today's topic of improving the work environment for seniors workers is a priority for us, and I'm sure for everyone listening. And I really look forward to learning with you all today. Thank you.
Thank you, Dr. Chubbs. Thanks very much for the sponsorship of your organization. And I think I understand you're one of the biggest organizations in Alberta in continuing care. So look forward to working with you. The title of today's webinar is Improving the Work Environment for Senior Services Workers. Research has shown that workforce issue is the most important policy area in the transformation of senior services in Alberta as well as in Canada. And priority action is needed to address this policy issue. With the aging of the population, we are in the danger of not having enough workers to provide services for the older adults. Improved work environment is good for the staff because it not only improves work culture and quality of work life of the workers, but it also improves the quality of care for the clients. So it is a policy issue we cannot ignore. We're very lucky in today's webinar. We are able to obtain internationally and nationally well-known experts to provide information to us on the current issues facing seniors care workforce in Alberta and in Canada. They will also provide you with evaluation of previous efforts and suggest strategy for addressing this issue in future. It is now my great privilege for me to introduce Alberta's own nationally and internationally recognized gerontology researcher, Dr. Carol Esterbrooks, as our first speaker. Carol has a track record of research and advocacy for a long time for better care for older adults, as well as better workforces for caregivers. She is the principal investigator of the track research program. She is also the chair of the Royal Society of Canada's study on restoring trust, COVID-19, and the future of long-term care. She's also on a number of important committees, such as the National Standards Development Committee for Long-Term Care Services by HSO, as well as the Alberta Facility-Based Continuing Care Review by Alberta Health. Dr. Esterbrooks will talk about strategies for improving the work environment for senior services workers.
Great.
Dr. Esterbrooks, yes.
Thank you very much, Vivian. I'm delighted to be here, and I'm just going to open my slides and hope that it all goes well and it shows up somewhere where we can all see them. I can't see them yet, so let me try that again. Okay. I've done something. Let me just change this a bit. I'm going to stop sharing, and I think you've got the slides there, Jordana, and maybe you'll just flip them up and let me have forward motion on them rather than fiddle away.
One moment.
So I'm delighted to be here. Let me just start before I get my slides up. I do most of my work, all my work in the residential long-term care sector, and we're talking more broadly about the continuing care sector today. most everything that's in one sector is also a factor in another sector. So some things that I will talk about in the residential long-term care portion of the continuing care system are more challenging than elsewhere, and some are less challenging. But my point of reference is residential long-term care. So I will be using that as I speak. So that's my title. And let me see if I have control. Maybe I do, and maybe I don't. I can't move them, Jordana, so maybe I'll just get you to advance it.
Just hover over the bottom left corner of the presentation screen and you'll be able to click through.
Oh, yes. Okay. All right. There you go. After 3 years, you'd think I'd know how to do this. 2 years, whatever it is. So most of us, when we think of work environment, we tend to gravitate right away to the physical the physical structure. And the physical structure is really important. And there's certainly movements going on in Alberta to move, if it's possible, towards small facility living. And we've talked before about green farms and dementia villages, and there are all sorts of models out there, some of them really brilliant. I like the equine one in Southern Arizona, but we all have our favorites. Those are important, but no matter how beautiful and spectacular and lovely the physical structure is and how much outdoors and sunlight time there is, et cetera, if the interpersonal and intrapersonal and relational and human aspects of the care environment aren't tended to, the care isn't better in these lovely facilities. So you can do really good care in really challenging old buildings built in the 60s and 70s. It's harder and it's not as pleasing to be in those buildings, but it's really at the heart of it, the relational parts of it. And that's what I'm going to talk about today. I'm not going to talk about physical structures. They are important. And we learned during COVID how problematic it is in some of these older buildings. And we need to refresh our physical structures, but that's not what I'll focus on today. This is a slide I won't dwell on, but it's to illustrate that the resident population in long-term care, and it backs up all the way through the system, has changed dramatically in the last 10 to 15 years. The length of stay in Alberta has plummeted. That's a result of deliberate policy initiatives to increase the aging at home experience and delay the onset of admission to long-term care. So that's a success story. It comes with a darker side. The Winnipeg line looks different because they have a lot of people in long-term care at this point that don't really need to be there. What that means is that people come to these settings later in the course of their dementia, in the course of their chronic diseases. They're much more medically and socially complex than they were 15 years ago. That has happened without a concomitant or an attending rise or lift in resources. So in effect, we've created, and this has happened in many, many jurisdictions, not just here, a net deficit in the kind of workforce and staffing resources we have. And we certainly we see that all the time, but during COVID, we saw some of the really challenging consequences when you start out in the middle of a global pandemic already behind the 8 ball by a lot. That's the residents. Let me talk about the workforce pre-pandemic. Pre-pandemic, what's important here isn't exactly what's on the slide, but look at the red pieces. Those are the percentage of workers in different categories at high risk for burnout. Burnout is different from traumatic stress. It's a more chronic, internalized condition. It affects quality of life and quality of work life, and it's more difficult to move it once you've become really burned out than it is to move some of the more temporary things that are related to the things that are happening. So in the pandemic, we had an already stressed, really, this is significant risk that this workforce is at. And we dropped a pandemic bomb on top of them. And of course, you've all lived the consequences of that. The good news on this slide is that this is an unusual, this setting, continuing care, and in particular long-term care, have unusually high levels of efficacy, or the sense that your work has meaning and value. We haven't analyzed some of our compassion and satisfaction data yet, but I'm anticipating that we'll see similarly high levels. And that probably acts as a buffer, which has made it better than it would otherwise have been. So it's a workforce under duress. Post-COVID, or sort of post, I'm not sure when it will ever end, because we're still experiencing significant deaths on a weekly basis in long-term care in Alberta from COVID. We have assessed all these things in a study that Alberta Health sponsored to look at the effect pre and post of the pandemic on well-being and emotional and physical and mental health of staff. But I have looked at the preliminary data, and it's not the same across groups. Managers have looked at this early stage like they've suffered some of the worst effects. So job satisfaction has changed in some groups, burnout has risen in some groups, mental health has deteriorated in some groups, and we have a new set of measures we've not worked with before. And when I take a preliminary look at them, they don't look really different than the broad health data that we're starting to get in around the world about the impact of the pandemic. But the scores on some of these are really high. We have significant numbers of people who are experiencing symptoms like insomnia and depression and anxiety, general stress and specific stress, general anxiety and more specific anxiety, secondary traumatic stress, which some people will understand as compassion fatigue, PTSD. That is not unexpected. And just a comment on PTSD. Not everybody will get it. Not everybody who gets it will have lingering effects, but there are a portion of people who have PTSD who will experience the effects for years to come, and they can be debilitating if they're not managed. We also looked at efficacy and resilience, and the resilience scores, I will say, are pretty impressive. And I think that's why long-term care has made do as long as it has and survived as well as it did, even though it did not survive well. As you all know, Canada had the poorest performance on the planet in terms of the proportion of the total COVID deaths in the population that happened in long-term care. They were at 80% in the early stages, and they're still running between 40 and 45%. That's really high. We also looked at intention to leave, and let me just make a comment about intention to leave. It's quite high in some groups. I've heard a lot of people talk, and there's a lot of concern about the Great Resignation, and I'm hearing from people that it started. So we have a global, really serious health workforce supply problem and crisis. We certainly have it here in Alberta, and we dropped a pandemic, another bomb again on top of an already pre-existing condition. So the work environment matters more than it ever did because it influences all of these things. It matters because we see better outcomes in all groups, patients or residents rather, staff, et cetera. It's easier to do quality improvement in a positive work environment, and it's easier to implement different initiatives and strategies that you're trying to do. So I'll spend a little bit of time here and not so much on the rest of the slides. The work environment, or the context, as we sometimes call it, the organizational context, but that means work environment, is like a set of nested dolls. There's the big outside or outer context that influences everybody, you know, the global, the national, and the provincial environment. And the province looks at things like legislation and regulatory activities and policy initiatives. And then there's the regional things. Though I'm not going to talk about those, but they exert really profound forces on the work environment. I'm going to talk more about what we're most familiar with. We have people, residents and families and long-term care, long-term companions and volunteers, et cetera, and staff of multiple kinds living on care units, and they're nested in care units, and the care units are nested in the homes are nested in the organization like Capital Care or Bethany or Extended Care or Good Sam. And the organizations are nested inside the zones, and the zones inside the provinces, et cetera. So if you think change is difficult in changing the work environment, it is because it's complex. It's not like a mousetrap game where you press a button and the little marble goes exactly where it should every time. It's much more like an amoeba. You push it, and some things that you think will happen do, but other things that you don't expect happen. Our group focuses mostly on the care unit, the resident care unit or neighborhood. They're called different things. That's the work environment where the residents and the families and the staff interact. That's where the environment really touches them the most. And most of the quality people, they call it a clinical microsystem, will tell you that that's where quality is made. So we focused a lot of attention there. And I'll talk a little bit about how we do that. It's modifiable. That's why we're working in that sector of the long-term care system, but it's not always easily modifiable. So we get a score, if you will, on context or work environment by measuring these 10 things. I'm not going to go into all of them, but some of them are easier to move than others. So I'll just mention a couple that are popping up more and more as critical. Social capital, which is about teamwork. Culture, which is about the way we do things and treat people here, essentially. I'm doing a really abbreviated version. We don't look at the big executive leadership. We look at the leadership, who the care aides report to. That's usually RNs and LPNs, and how that part of leadership is working. And there's just plain up hard sweat equity resources that are important. And those interaction bubbles really are different kinds of communication. So we take that, the measures we get from care aides, we get them from everybody, but we use the care aid ones because you need enough responses to be able to roll them up so you see what the unit's doing. And we spin them in a centrifuge and pull them apart so that we can separate the homes or the units into green and red. So a better environment's green and a not as good environment is red. And we see that we get lower symptom burden at the end of life. So shortness of breath and pain, as two examples, are less. If you don't do anything, the scores are better in green homes or work where the work environment's more positive. The care aides in this case report better physical and mental health scores in green homes or positive work environment homes. And you have less missed care and also rushed care in green homes. So without doing anything with the, well, it's not exactly true, you don't have to do anything with the people, but without doing education and adding resources and doing all the things that we often do, if you work on the elements of the work environment that make you green or greener or more favorable, you can move these outcomes. So it's another pathway to work on that's been ignored historically. So what do we need to do that? Well, we need better data, and not because we need it to do research. We need it because if you don't measure it, you don't know where you are and whether you're going up, down, or sideways. We have extremely limited data on the workforce. We don't even have basic demographic data across this country. We have no data except in research collections on quality of work life and physical and mental health and well-being. There's almost no data on the work environment that is reporting what it's like. There are serious gaps in what we know about leadership training and continuing education, although we know some things, and around communication, which not only ourselves, but others in the province and elsewhere have identified repeatedly is a major component of the, what I would call the social capital, and some people will call it the culture of the work environment. I'm not going to talk about and get into the weeds about hours of care, but you can't talk about the work environment without at least acknowledging that if you can't put food on the table, it's hard to self-actualize. So if you don't have enough people to do the fundamental basic work, it's hard to work on some of these other things. So there are recommendations. They're limited, but they do exist about hours of care. But just buyer beware. The standard recommendation that the whole world cites is we have to have 4.1 hours of care. It was done in the United States 20 years ago, and it's no longer relevant. However, 4.1 is a whole lot better than where we were before the pandemic. So it's an intermediate goal. If you talk to, and Pat may talk about this, to experts in the field who've been in it for decades, they will tell you that the hours that we need to ensure basic needs are met in these environments are significantly higher than this, but it's a starting place. Canada's particularly bad about having data on this element. So what are some strategies? We know a lot can be acted on without more data or more study, and we should always remember that. We can, as much as is humanly possible and possible within the political and policy context, boost staffing and other resources, and do that as quickly as we can. It will make a difference. We can look hard at how work is done because there aren't going to be enough staff, even if we had 6 hours of care, because we have this huge supply problem. So we're going to have to work. I know it sounds kind of motherhood and apple pie, but how we work. We have to attend to the support, preparation, and ongoing professional education of managers and supervisory staff. They are not adequately supported. We have to pay attention to what the managers are telling us was wrong during COVID, because they have a bird's eye view that the rest of us don't have. And we've got to have better employee stress and health-related supports. And that probably means, among many things, employee assistance program overhaul, and really looking at tailoring those programs realistically to the different groups of people. We do need better information and data, however. We've got to look at the characteristics of the paid, volunteer, and unpaid labor workforce in all settings where older adults are cared for, not just long-term care. And we have to have better information about the actual work environment factors that matter. We need to test and adopt new things and move them from pilots. We need to stop doing pilots only. We need to move them to implementation and figure out how to do that, and then evaluate it when we do, so that if it's not working, we can stop it and take those precious resources elsewhere. The public and advocacy groups need to keep the heat on, turn it right up and keep it on. The province, like all provinces, are aging rapidly, and we don't have the luxury of time. So we need, and there's a lot going on in the world. There's fires and floods and wars in Europe, and gas is $5 a gallon, and it goes on and on and on. And those are important things that affect us, but we can't let them push long-term care out of the spotlight. And I think, speaking as an academic, that all professional and vocational programs need a penetrating look, because we're partly responsible for the attitudes that exist and the lack of interest that sometimes people express in dismay among our really young and talented physicians and nurses and allied professionals. So thank you very much. And I look forward to questions later.
Hi, thank you very much, Carol. Yeah, you sure have draw us to attention of a number of new domains and strategies to look at, and we definitely should talk about that later. Now it is my great pleasure to introduce Dr. Pat Armstrong from York University in Toronto. Dr. Armstrong is a distinguished research professor emeritus and fellow of the Royal Society of Canada. She was the principal investigator of the research project, Reimagining Long-Term Residential Care, an international study of promising practices. Dr. Armstrong. You're mute.
Yeah, I realized that as soon as I, like Carol, I should have learned all this stuff already. Anyway, thank you for this opportunity and for paying attention to the conditions of work. Whoops, I'm having trouble here like Carol did. And like Carol, I'm focusing on long-term care based on our 6 countries studies that we have been doing, including the one that Vivian just mentioned. We too have been looking at multiple layers, as well as doing ethnographic studies in homes in all these countries. But I'm happy to talk about the other areas later because I've done some work there as well. So we have long argued that the conditions of work are the conditions of care. And we've also argued that in looking at those conditions, we have to consider the entire range of those who work in, visit in, and live in long-term care. So in my 10 minutes, I want to focus on those seldom considered people who are included in that group, namely the dietary, housekeeping, and laundry staff, private companions, and families. The military reports on their experiences in Ontario and Quebec nursing homes made it clear how critical food, clean rooms, and clean clothes are to survival. We argue that they are much more than that. They're central to the well-being of residents, and the conditions under which they are done have an impact not only on the workers, but also on the residents. As we set out in our book, Wash, Wear, and Care, clean clothes and clean rooms are about dignity and respect, not only about infection. Food should be a social experience and promote the pleasure of taste, not simply about ingesting nutrients. The contracting out of these services has profound consequences for both those who do the work and those who use the services. In a BC home we studied, prepared trays on huge industrial carts were rolled in by these workers who had to consult a floor plan on the tables and places where food was to go. The contracting service put up a big sign in the dining room that said, "Do not talk to the workers." The lack of interaction made the job more difficult for workers and less satisfying for them because they had no opportunity to know residents. At the same time, the residents had no opportunity to chat or even have their individual preferences addressed. Food prepared off-site provided no tempting smells to stimulate appetites, and fully loaded pre-cooked meals turned residents off, especially if the tray included a vegetable they hated. A cleaner employed by a contracted firm explained that she was transferred from the airport cleaning and provided with no additional training except being told to avoid working in a room alone because she would be accused of stealing. She was upset, though, when the company moved her from the 2 floors she'd been working on for a while. With a regular floor assignment, she got to know residents and their families, enjoying long chats as she cleaned. Indeed, we've often heard that residents talk most frequently with these so-called ancillary workers. Many of these contracted workers are not unionized and have limited wage benefits and job security in large measure because they don't have unions or other job protection. Some have no sick leave, creating a risk of them working while ill and thus spreading infection. Contracting out services is certainly not the only problem with the conditions these workers face. Laundries and kitchens are often in windowless, badly ventilated basements, far from residents. Machines, especially for laundry and cleaning, are often huge and cumbersome, resulting in high injury rates. Opportunities for training and promotion are usually missing. And these workers are often excluded from team meetings and segregated from other staff, to name only some of the issues. And Carol has made it clear why teams are so important. But we did see alternatives. In a Nova Scotia home, their chef, who'd been sent by the home to a cooking school, worked with her staff in a bright, effectively ventilated room on the 2nd floor. Kitchen staff delivered food to each household, pushing around a cart that allowed residents to choose and to chat. The untouched leftovers provided the cooks an opportunity to be creative in using them for the next meal, thus creating variability in the menu, as well as avoiding the waste in full trays sent to the garbage. In an Ontario home, the chef was concerned about how pureed food was putting off residents, so she would show them the food plate before she pureed the meal, which encouraged more eating and, of course, avoided that prepackaged pureed food. In a UK home, the chef noticed the full plates were returned uneaten. He tried serving food in small bites with choices. Nutrition levels went way up. By allowing these workers some autonomy, the workers had satisfaction in making a difference, and residents were happy and they ate more. A laundry room in a Manitoba home was also in a bright ventilated room, and laundry workers personally delivered laundry to each resident, putting the clothes in the residents' closets and drawers, chatting while they did so. Not incidentally, this ensured that clothes were not lost or wrecked, as we heard so often about in the other homes we studied. In a Swedish home, all staff met regularly as a team to discuss residents as well as other issues, assuming all workers have skills and knowledge worth sharing. In one home, the staff was involved in developing new carts that were easier to push and to fit into difficult spaces, reducing injuries while improving cleaning. In a Manitoba home, the housekeeping staff was concerned about the contamination risk of the old rags they were given to clean, rags that were later thrown out after their first use. They suggested instead color-coded new material that could be assigned to only one type of cleaning, then washed and reused. But time rushes on, so let me turn to private companions. Variously named, these are the increasing number of people hired by families to provide care to fill the increasing gaps in care. Of course, only some families can afford to hire such workers, creating inequities in care. They primarily report to families, and the rules around what these workers are allowed to do and not do are often unclear or even non-existent. The companions, we find that they were often stopped from doing something or chastised from doing something, and that's the way they found out what the rules were. In our cross-country research, we have seen no consistency in the regulation or training of these workers, no regulation of wages or of hours. Few homes know when these companions will be there, creating problems for the home in terms of planning and tension with the staff who question the companions' skills and suspect them of spying for families. Indeed, we were told by one home that their lawyer had advised them not to document or regulate private companions because that could make the home liable for any injury these workers experienced or caused. Such companions were rare in Sweden and Norway, primarily because the staffing levels are more than twice as high as they are in Canada, and families thus expect the care to be there without extra hands. So let me turn to families. As the pandemic made clear, families are increasingly expected to provide care that goes well beyond visiting and social support. So we need to think about their conditions of work. In our current study on families in COVID, families tell us they want more training. They want more participation in decision-making, participation that goes well beyond satisfaction surveys or consultation on a care plan. They were particularly upset with poor, irregular, and inconsistent communications during COVID. I would note that many suggest that all residents have, as they do in Norway and Sweden, a designated nurse who takes primary responsibility for communication with the resident's family and who can be contacted in most any time by that family. Like the private companions, families often faced a clear lack of guidelines on who can do what, when, how, and with whom. And of course, they want more staff and more training for staff. So I've only touched on some of the critical working conditions for these workers. I've argued that they are all central to care and we need to attend to their working conditions, just as Carol has made clear in general about the entire staff. So thank you, and I look forward to your questions.
Thank you, Pat, for your very interesting observation. I'm glad that you mentioned a few groups like laundry, housekeeping staff, chef, and of course, most important, families as well. Sometimes we don't talk that much about laundry and housekeeping staff. So we can definitely discuss that in our discussion session. Now it is my great pleasure to introduce our third speaker, Colleen Torganrod, clinical ethicist from the Alberta Health Services. Colleen has training in both social work and psychology and held a master's degree in medical ethics from the University of Keele in UK. Colleen will talk about addressing the post-pandemic mental health needs of seniors workers.
Thanks very much, Vivian. It's my sincere pleasure to be with you all here today, and thanks for joining us. It's kind of full circle for me as I inch, what feels like inch towards retirement. When I started my first undergraduate degree in the late 80s, the focus was on sociology, and my plan was to concentrate on criminology, and I hated it. But as luck would have it, one of my final electives was in gerontology, and that's really shaped so much of my career, education and career and experience since then. So it's really an honor to be included today. Sorry, there we go. There we go. A couple of quick disclaimers. I have no conflicts of interest to disclose. I have no formal ties, financial or otherwise, with any of the sponsors of this event. And most importantly, please hold me responsible for anything I might have to say today. I am an employee of Alberta Health Services based in Edmonton, yet I make no claim to speak on behalf of the organization itself. So how true is this? We cannot walk through water without getting wet. These last couple of years, going on 3 now actually, have been really tough for many, many reasons, and many of us have been going through a lot. The pandemic has affected all of our lives and caused us to ask a lot of questions of ourselves about our beliefs, our values. What we focus on in the clinical ethics service is values tension. And we're clinicians in that regard. We're not employee assistance people or therapists per se, but as you'll see in a slide that's coming up right away here, there's so much overlap between what is moral distress, what's burnout, what's grief, what is loss. All these things intersect. This particular time has challenged us to reflect on what's important to us, about our work, about the patients, residents, clients we look after, and truly about our personal lives as well. So at the outset, it's worth commenting that the pandemic has been a double blow for our experiences with distress, particularly moral distress. It's created more incidences of moral distress and has increased the frequency of people's experience, although everybody's not going to experience the same thing in the same situation. We have reduced time and energy to address the experiences of this distress, and we haven't been able to do many of the things that could have helped us to address it, such as group activities, gathering with friends, and supports that have all been curtailed by public health measures. So this is what I alluded to a minute ago. You see how these things overlap and intersect and affect one another. What's called our assumptive world, this is a term from grief and bereavement. We often don't know what our assumptions about life and what's coming next are until they've been torn away, typically unexpectedly. And there was no room for this COVID thing to happen, particularly in seniors care. The acuity that's, since I started work more years ago than I'll admit to, in long-term care, continuing care, is just a whole different ballgame than it was then. And staffing levels don't reflect that. Distress doesn't refer to all the challenges or painful emotions that may be experienced in caring or in our lives. Some of these experiences may be appropriately captured under some of these other headings, and there's overlap, as I said. And they can also affect and reinforce each other. Compassion fatigue can cause moral distress. Unaddressed moral distress can lead to burnout. As a result, the symptoms and consequences of each can be similar, and the strategies also similar to address them. So specifically, what's moral distress? It's the psycho, emotional, physiological responses of an individual who feels unable to act in a way that they believe to be consistent with deeply held ethical values, virtues, principles, or moral commitments because of constraints, be they institutional, political, interpersonal. And again, the focus in our service typically is on moral distress, but you can't talk about one without touching on the others as well. A colleague has said, we have lost centuries of experience due to attrition and people quitting. Sorry, this illustration isn't a bit clear, but some of you Winnie the Pooh fans may recognize it. It's called Walking Away, and it's Pooh and Piglet literally walking away. And we truly have lost people. Seniors care workers in Alberta, particularly those that worked in long-term care and continuing care, extreme burnout, moral distress, depression. Many of them worked in units with over 50% of folks with COVID. Very high percentage of fatalities. And as Carol noted, our track record in Canada is particularly abysmal. We did not have room for this to happen. Some folks are only now trying to recover from the stress. Contracted workers in private and nonprofit facilities are usually not eligible for organizationally funded mental health counseling and support. And many are asking for this. There was a survey that we did in conjunction with another presentation that really mirrored some of the comments, and I'll quote these in a sec, that have been said to me in the course of the ethics consultation that we've done and that we continue to do. These are from care providers. I've been spit at. I've been pushed. My vehicle's been damaged. My heart is broken watching people suffer without their loved ones present. It's interesting when the others touched on the great role that family can play. And then all of a sudden with visitation restrictions, they were told to stay away. And what did that mean? I felt so inadequate. I don't think I can go on. So there are three kind of pillars in ethics that we look at that you're probably quite familiar with, this one anyway. The principle base, what autonomy, don't do any harm, be of benefit, what's fair. Then there's relational ethics, and I'll talk about that in a little bit. And most certainly, Pat touched on this, the importance of the relationships that we have with the people for whom we care. So what about virtue ethics? This is language that we don't often focus on or think about. What are the qualities of character that motivate and guide each one of us individually? Our list of non-negotiables. So just think for a sec about what yours might be. And have they of late felt ignored, violated? And that only at the very least results in distress. So these are just some words to put out there to consider from Aristotle. Talks about virtue of wisdom, courage, justice, prudence, fortitude. What buttons get triggered if some of those are on your list of things that motivate your behavior? Lao Tzu 2,500 years ago had 4 that I find really powerful. What does it mean in action to be reverent for life? What does it mean to be gentle? What does it mean to be generous? What does it mean to be sincere? And have we been able to live those things as fully as we want to? So just a quick example of one of the things that certainly has pushed some of my buttons and many other people's. It's the redeployment that's happened. Again, going back to the importance of relationships, especially with our older generation who grew up in community. Maybe many of us don't even know who our neighbors are, but that's not what the folks we're caring for, in whatever context, have grown up with. It's about relationship. So why is it so important to reestablish consistency, and how can we do that? Consistent caregivers transform caregiving from tasks to relationship-based care. Consistency is the foundation for high-quality, individualized care. That I'm caring for you the way that I understand is meaningful to you and feeds into good teamwork. Consistency provides stability for everybody. One suggestion how to rebuild, this is from the Palliative Care Association of Alberta, is to do what they talk about as huddling up again, which we didn't have time for, didn't have the staff for, sometimes in some places still don't. But how do we get together with one another, and how to do it? You keep the conversation constructive and kind and regular. Discourage personal comments. There's no shaming or blaming. You come from a place where believing that almost everybody is really trying to do the best they can. Encourage creativity from everybody, all levels, all roles, especially the providers that know the client best. Keep things on topic, work with a regular agenda, and give special attention to residents, clients, patients who are at risk. So the old oxygen mask mentality, we need to take care of ourselves first and our teammates in that order. And then going back to virtues and when you give it some thought, what you think yours might be, which of them need attention right now, which need oxygen. So thanks so much for who you all are and everything that you do. And thanks for your attention.
Thank you, Colleen, for your presentation. And we are so glad that you talk about an area which was very often neglected, which is the mental health needs of the workers. And I really like your emphasis on consistency. So definitely give us something to think about. Now, in this segment of the webinars, we invited 3 discussants to discuss workforce issues from their own experiences. The first discussant is Elstime Akayode, who is a frontline LPN. She's also a head of a healthcare aid training program. And she will talk about workforce issues from the perspective of a frontline worker.
Good afternoon. Thank you, Vivian. I am delighted to be here today to share with you some of my observation about problems faced by LPN, HCA, and HCA students working in long-term care. I applaud the AAG for seeking comment from a frontline workers on ways of transforming and improving our seniors service system. I think it is extremely important to hear about the frontline concern. Currently, we have so many challenges in the healthcare world, but I wanted to focus on just a few. The first one I would like to bring light to, that is not often spoken about, is the strong cultural disconnect in seniors building and long-term care, both for the staff and for the resident. Let me elaborate. Residents have either not have been exposed to vast cultural environment, or they carry stigma regarding certain culture or ethnicity. This creates challenge for the staff to provide care and operate in a peaceful and collaborative environment. Residents will often be cautious, disregard, be quite disrespectful, or even make inappropriate remarks towards staff that are from a different culture than them, or a culture that they may not respect or understand. This is a very tricky one, let me tell you, because that caused lots of unnecessary tension and division within the unit. This dynamic has been observed among staff also. Most often, staff will create barriers within their own unit, and they tend to cohort with others of a similar culture or background. This also creates lots of division. In my humble opinion, one of the solutions could be more education session that explain cultural diversity. Different culture would be very helpful. In previous places that I have worked, we all know there's education session and physical needs, lift, transfer, feeding, CPR, etc. But rarely are there an emphasis or focus on the social aspect. I think providing education in different cultural, religious holiday, language, custom will go a long way in assisting us to create a more positive, collaborative teamwork environment. The other pointer that I wanted to touch upon is the lack of time for nursing staff, HCA, HCA student, LPN, to provide holistic care for our client due to, of course, staffage shortage. Not only is this very detrimental to our client, but it's also really weigh heavy on our heart because we feel like we are not doing our job to the fullest. This problem was really brought to light for me when I started to teach clinical placement. Students can focus on all aspects of care for their client, whereas the staff does not always have that luxury. HCA instructors within my team has had the opportunity to incorporate meaningful holistic care into the students' days. For example, spending 20 minutes with a client can literally make their entire day better. Simply sitting by them, having a cup of their favorite tea or coffee, bring them such joy. They feel heard, valued, and cared for. They feel that social, emotional connection that often they greatly crave. They have been deprived of this, especially due to COVID. Residents start to look forward to this one-on-one visit with the student. They are genuinely sad to lose those students at the end of their clinical placement time. I see smiles and genuinely appreciation from student and resident alike. That opportunity that the student have to provide that one-on-one brings some challenges. Regular staff often complain of not having that time to provide that important one-on-one interaction. Seeing students having that luxury opportunity brings some type of enviousness within the unit. The staff complain that the students are lazy. Then I get that information back and have to give that feedback to the student that they are not lazy. They are doing what we're all supposed to be doing. But we have to understand where the staffs are coming from. With the task-oriented, being focused only on the task that they must have done, they do not have that luxury to take that extra time to sit with a client. So we understand their point of view. Okay. In terms of providing holistic, personalized, meaningful care for our client, that is the first one to be neglected due to budget cut or staff shortage. I think some of the solution could be implemented if we're able to standardize them with the government. One thing that I think would be helpful to help the staff deal with the pressure of providing all the necessary care, but without having the time, is if other other departments could provide some of those care, such as PT, RT, being able to provide help with feeding, companionship, etc. So another idea that I have been personally involved in is bringing the HCS students and inspiring them to do volunteering, which also help with the staff shortage at site.
We have to move on to the next discussant, so thank you for your time. Vivian?
Thank you. You raised a lot of areas in which we definitely could discuss further, but they are very useful information from you as a frontline worker. Now we go to our next discussant, Karen Mcdonald. She's the chair of the Community Leadership Council for Healthy Aging in Alberta, and her topic is workforce issues relating to community-based service worker.
Thanks, Vivian. Next slide, Jordana. The Healthy Aging Alberta initiative is a collective impact approach that seeks to bring together community-based senior services sector collaboration, coordination, and integration to ultimately improve health and social outcomes for older adults. Next slide, please. Healthy Aging Alberta focuses on the development of a coordinated community-based senior services sector that is respected and integrated within the broader senior system of care and can empower and inspire every senior to age how they choose, ultimately improving health and social outcomes for older adults. That's why today, I'd like to speak more about workforce planning and volunteer sector trends within the community-based senior services sector. Next slide, please. 91% of seniors approximately in Alberta live in private dwellings, with nearly 16% living in apartment buildings and almost 71% living in single detached homes. This means that in Alberta, approximately 637,000 seniors live in community settings where they may rely on community-based organizations to access services such as transportation to appointments, shopping and banking, meal services, or direct supports in accessing food, supports with elder abuse, tax filing and help with forms and access to financial benefits, system navigation, social opportunities and programming that addresses isolation, home services like yard maintenance, snow removal and housekeeping, language and cultural supports, and many more. Staff roles in these organizations include to deliver these types of services often include social workers, community developers, community health workers, and professionals with education and credentials and expertise in areas like volunteer management, fund development, nonprofit management, evaluation, grant writing, and reporting. There are 26,000 nonprofit organizations in Alberta that employ 286,000 Albertans. Of those organizations and workers, approximately 10% could be classified as social services, which is likely the largest category of services in this community-based senior services sector. Canadian data tells us that the paid workforce for the nonprofit sector is predominantly female, older than the for-profit workforce, and with a high percentage of well-educated professional staff, which may be a surprise to some, as there are some stereotypes and myths about the nature of the nonprofit workforce. And in the community-based senior services sector, where many community organizations are led by seniors for seniors, there's also ageism at play in terms of how the workforce is perceived by other sectors and by funders. However, we don't yet know a lot about the community-based senior services sector because the workforce here in Alberta, we don't yet have a workforce strategy for the sector. But with the emergence of Healthy Aging Alberta, we are now in a position to advance data collection and a strategy in this area. In Alberta, we often don't necessarily recognize the role of volunteers in the sector either, with over 5.6 billion of time annually across the nonprofit sector. That's approximately 134,000 full-time equivalent jobs represented by volunteering. We don't yet have specific statistics of how many of these hours support senior services, but I can tell you, for example, that in our organization at SAGE, approximately 1/3 of our HR hours in pre-pandemic year were provided by unpaid human resources. So we need to consider that in terms of our HR planning. Next slide, please. Oh, there's a picture of our volunteers. So key challenges and opportunities for workforce planning, sorry, next slide, Georgiana. In the community-based senior services sector include understanding the size and composition of the sector's workforce, the quality of paid and unpaid jobs in the sector, changing skill requirements, the incidence of training, organizational strategies, and human resource practices in the community-based senior services sector, and alignment with current and future policy priorities that will impact the workforce. Funding has become increasingly short-term and targeted, which makes it difficult for organizations to support core functions and invest in the capacity for the long term. Wage disparity between the sector and other sectors creates a pipeline where new grads start their careers in the CBSS organizations, who invest in training and then staff leave for higher paying jobs in other sectors. Working with Healthy Aging Alberta and a coordinated funders table to move to more sustainable funding models will address some of these workforce challenges, at least in part. There's currently no systemic approach to connecting the needs of community-based senior services sector with academic institutions. And we know that this is a key gap in our current approach to supporting the work of these organizations. Next slide, please. Healthy Aging Alberta looks forward to working with AAG and our colleagues across Alberta to develop a workforce strategy with community-based senior services sector that will address these opportunities and challenges so that these organizations can best meet the needs and strengths of seniors living in community. Thanks very much.
Thank you. Karen, it's so important that you draw our attention to focus on the need of the senior social services workers area, as well as the importance of the needs for recruitment of volunteers. So we definitely will look at it as part of the workforce issue in future. Our third discussion is Darren Furnell, the Area Director of Bayshore Healthcare in Western Canada. He will talk about workforce issues relating to home care workers.
Thanks, Vivian. Thank you all for attending. I have quite a bit to cover, so I'm going to speak quite quickly. If anyone has questions after, we should have time. So I represent both my home organization and the Alberta Continuing Care Association's home care group, the vendors that work within ACCA. So of that group, we're looking at close to over 5 million hours of home care provided to Alberta seniors per year. So I want to talk a little bit about home care realities in the workforce. I think Dr. Esterbrooks said it well, that we didn't have room for COVID in the problems with the workforce. COVID is not the only issue, but it sure didn't help, as title here. I go through a few things that happened with COVID that really drove a dagger in the heart of the home care workforce. On March 13th and the following 7 days, 45 to 50% of authorizations and for home care were eliminated. We went to what was called a emergency services model for good reason, and to free up capacity. Unfortunately, that capacity wasn't utilized by AHS. So eventually, and not that long in happening, the workforce moved on to long-term care, supported living, and otherwise. So theoretically, it was a very sound move, but because the capacity wasn't used, the workforce slipped away. So that was a great number of people in the high hundreds from just a few vendors. Also, as you know, there were no healthcare graduates at that point, so they, we're home care is a entry-level employer, so having no cohort from the colleges was a real difficult situation. The $2 stipend that healthcare aides received in long-term care and supported living wasn't given to home care workers until just this last September. So they went over a year with a very large gap between the LTC and home care workers, and even emphasized by that $2 that was given to LTC and still remains in place. Single site restrictions, of course, really affected things drastically in home care, even though the rules were not set up that way. Most long-term care environments restricted any staff coming and going with good reason. Home care was supposed to be exempt, but that didn't happen in practice, even though theoretically it was sound. And then families were forced to take up the slack in the home care system. Some could because they were now working from home or back at home, but a good percentage of them were not able to take up that slack. So COVID was a massive blow to the home care workforce, and continues to be to this day. So we're coming out of it. This is very positive. Home care authorizations are increasing. We're not in an emergency services environment anymore, but we still remain below pre-COVID levels in many jurisdictions in terms of the number of home care activities that are being done for Albertans. As much as 20% of home care staff departed and have not come back. So they went to other environments within continuing care, long-term care, or other areas, and they didn't come back to home care. And no appreciable uplifts have been given in the home care space from AHS and from the government to fill the gap that is between the home care workers and the workers at long-term care, which is $4 to $5 an hour. Home care work life itself, and this is a topic for much discussion, of course, is what does home care workers do? What do they do? Well, they work in the morning, they work in the evening. They don't work in shifts. They have split shifts, unpredictable schedules, and it's quite difficult to maintain that workforce. So do we have a brighter tomorrow? I think we do have a brighter future. We just saw a huge RFP dropped from the government, which will be all 5 zones, 12 care areas in home care, potential for 8 million added care hours for Albertans. In a year from now, home care will not look as it does now. But this is not going to be sustainable. It's not going to happen unless we look at what HCAs in the workforce, the home care workforce, are getting out of the deal. Comparable wages, decent shift dynamics. That would be you work days or you work evenings, not 2 hours in the morning, 3 hours in the evening. You have considerations for travel and the serious challenges we're facing with the economy and inflation. And then there's major urban versus rural considerations for traveling home to home in the rural environment versus the urban environment. So that's what I have in a nutshell. Thank you, everyone, and we'll move on to Q&A, I believe.
Thank you, Darren. It is very important you highlight the issues facing home care workers, because in fact, it is the growth factor in future in continuing care. So we definitely need to pay a lot of attention to that. So I'm going to turn it over for John Dana, who will look at the Q&A from the audience.
Thank you, Vivian. If you would like to submit a question or a comment to any of the panelists or all of them, please click the Q&A button at the bottom of your Zoom screen. You can also upvote other attendees' comments or questions by clicking the thumbs up button. And you'll be able to view questions that have already been answered. So the first question is from Maureen. Has there been any thought given to offering shorter but regular shifts to attract older workers who no longer have the stamina for long shifts, but who still have a lot to offer? I will open this to the floor for any panelist who would like to answer.
I can take a kick at it. I don't know if there has been any kind of deliberate thought. The workforce in long-term care is predominantly women, and it's already skewed to be an older workforce, not entirely. And so I don't have a sense of whether that would attract workers or not. Probably it's been explored in some jurisdictions. I don't know if others have a perspective.
If I could jump in there, what is really important from the research we've done is having some control over your scheduling. And during the pandemic, they didn't have any control, and that's been really critical. In Ontario, they suspended their right to refuse shifts and extra shifts and weekends schedule balances. So I think the bigger question, whatever your age, is the capacity to have an influence over that scheduling. And it's one of the reasons so many of them are going to agency work, is because that gives them more control over the hours of work. So it's a more general question, I think, than that specific solution. I wanted to say something in relation to what Colleen said. 15 years ago, we did a survey of staff in long-term care in the Nordic countries and in Canada. The Canadian workers were more than 6 times as likely to say they face violence on a daily basis. And there's no difference in the resident population in these countries. The big difference is in the staffing levels and the autonomy to staff, which is related to what Ernstine was saying, I think, in terms of direct care workers, that they need the capacity, the time, and the right to apply the skills they have in the time available. And the other thing I wanted to say in relation to what she said was that we've had a lot of reports of heavy-duty racism and sexism, and also, as Colleen said, I've been hit, kicked, bitten, slapped, pinched, arms broken, and this is long before COVID. With COVID, it just got so much worse.
Thank you. The next question is from Sharon. Carol mentioned that care is more complex in the long-term care congregate care. What about the care home done by home care and family caregivers? Is that more complex too?
The care in homes?
I believe so.
Yeah. The more advanced the trajectory, dementia is driving much of what's going on. Well over 90% of people in a nursing home have some form of cognitive impairment, and about 2/3 have an official diagnosis. And dementia is a life-limiting progressive disease. You can't cure it. You can't even moderate it a lot. So as it progresses, the care is more complex, not so much the medical care, although that is, but the everyday interaction care, all the activities around daily living. And so if it's more complex and heavier in long-term care, it will be in assisted and supportive living. It will be in the home. So the longer you keep someone at home with dementia, the more complex it's going to get. And it takes many forms, because dementia, of course, isn't one disease, it's many, it's an umbrella term. What usually, or not usually, but what often tips the scale to admission to a facility is when their older adult becomes incontinent, and that becomes unmanageable at home. But there are other things that tip it too, all sorts of other things. So I would say kind of at a general level, yes. I don't think we pay enough attention to that, because the system's connected. It's not just a silo of home care and a silo of lodges and a silo of et cetera, et cetera.
I can confirm that we have a lot more complex clients starting with higher number of hours on a daily basis than we did, say, 5, 7, 10 years ago. They're starting with considerably more hours in the home care.
I think we also need to recognize that a great deal of this unpaid home care, most of it is done by women, right? And often to the sacrifice of their own health and their own future, and often without, they feel we have a current study about the move into long-term care, what happens when you go in and what were you doing before. And it's quite impressive, I think, the range of things these family members have been doing in the home that they wouldn't have dreamed of doing in the past, and often feel inadequate doing it because they don't have the medications required. I interviewed a woman in Alberta who said, and it's related to what Kara was saying about dementia, whose husband kept getting out in the middle of the night, and she was too strong to stop him. And there were no locks that she could undo that he couldn't undo. And first of all, the neighbors helped her, and secondly, the police helped her, and both groups said, look, we can't do this anymore. And that was the tipping point for him going into long-term care.
The other thing about, just to piggyback onto what Pat said, is there's a perception sometimes that the burden's really high on families caring for someone at home, but the perception is when they go to a care home, it somehow evaporates, and sometimes it can be even worse, because it's not like home in a care home, and there's guilt, and if the conditions are really not good in the care home, it has a really major effect on people who've been previously doing caregiving at home.
I think also the levels of some form of dementia that you mentioned too, the move in and of itself from one place to another can be absolutely debilitating to the individual themselves, trying to make sense out of where they are and what time of day it is and where's my family. And systemically, to go a little bit back to the level of care that people are receiving. And some of my best friends work in acute care, so I won't throw anybody under the bus, but there's a term about the tyranny of acute care. And I think there's something to be said for that. If you watch more news than most of us should watch, the level of support and resources that went into trying to bolster acute care came at the expense of people who couldn't handle this anyway, I think.
Absolutely. And I just want to point out, and I know we all know it, but sometimes we forget it. We saw people and we read about on a daily basis the horrific level of critical illness those people had in tertiary level ICUs, and how excruciating that death process was. It wasn't any different in long-term care, just because they weren't on a ventilator and turned prone with 5 nurses looking after them. So I think we underestimated, there's kind of this general, they're old and they're going to die and they'll just peacefully go to sleep. And I talked to people where in homes where the hospitals came and said, we need your PPE. They stole it from them, saying it's more important. We've got really sick people. So that's part of this big marginalized position that older adults and women and long-term care, there's just a convergence of things that intersect that we need to get straight about, I think.
Well, and long-term care is mainly for women by women, right? Which may help us understand why it's so neglected. I wanted to add two quick things, and then I promise I shut up. One of them is that a recent survey in Sweden of seniors, a majority of them said if they needed help with more than two things in the home, they would like to go into a long-term care. Which I think is a very interesting result. Although I also hear that, you know, more than 90% of older people don't want to go into long-term care. It's a good thing in Ontario because only 4% get into long-term care in the end. And the third thing I was going to say has to do with the skills question. We did a study for the Ontario Nurses Association and interviewed the nurses who worked in long-term care. And one nurse said, my friends all told me when I went into long-term care that I'd lose all my skills. And she had previously worked in acute care. And she said, I tell them, have you got to be kidding? Today I use my entire range of skills. And she listed them all in order.
Thank you. I have a big question for all of you. And by the way, I do want to observe, sitting back, having heard all of you, and I have read a lot about the literature and research in this area because it's an area of my research as well. I must say your presentation are just outstanding because the examples get us so close to the real life we had heard about before. So you together, having heard all of you, it certainly paint a picture to us. My big question is, the picture painted to us is that this is quite a very huge problem and very complex. You have issue home care, long-term care, and social service worker. So if you are a planner, which I am, or if you have a role of an oversee person, how would you start addressing this workforce problem if you have influence on that? And whose role do you think is to fix it? Because it is a big problem, not one. I don't think one person or one area can fix it. So how would, if you are a systematic planner, how would you even start addressing the problem, and whose role is responsible for addressing it? Anyone can
I take
address
a kick at that. And Pat was on the task force with me at the Royal Society, and we sit down, and after we tried to boil the ocean, had a conversation one day. If people did nothing else and they addressed the workforce issues, that would be where to start. But we also, it's not one person's, it's a multi-jurisdictional issue. But we need a plan, because if we don't have some kind of roadmap, however imperfect, we won't know where we're going or how to get there or when we get there. But we got to chunk this down. We can't fix it. There's not a quick fix. I think it's going to take something like a 5 to 10 year strategy. We have to figure out how to provide enough resources so the care can get done, so people don't die in the conditions they died in during COVID, and that they can have good quality of life. And you know, Vivian, at the core, you know what it is. It's a values issue. That's why it's such a, we don't value old people. That's what the core root problem is. But if we assume that we have good people in good jurisdictions working in good faith who do value people, we just chunk it out. I was talking to a government person this morning saying, can't fix it all at once. We're going to start here, and then we're going to do this, and then we're going to do this, and we're going to try and dodge the election cycle, and we're going to do this. And it's just grinding work. It's just grinding. But we've got to engage young people. That's why I think the educational institutions are so important. We have really bad attitudes in lots of the different professional groups when they come out of their basic education about older care, older person care.
Anybody else want to comment?
Jump in, Vivian.
Yeah.
As we're talking a little bit about whose responsibility it is, I hope that we'll look at, building on what Carol said, intersectoral approaches to workforce planning. When we make policy decisions around, let's say, facility-based care and policies related to how seniors will age in those facilities, how many beds we're going to build, how we're going to shift care into community. When we don't take a systems lens to workforce planning, there's unintended consequences to those decisions. So right now, for example, when we talk about the complexity of care that's being provided in facility-based care and the impact on workforce, we're having the same impacts in community-based organizations, the people that are responsible for delivering meals and transporting seniors using volunteers to their medical appointments and supporting caregivers. All those community organizations are also seeing an increase in the complexity of the seniors they're trying to support in community. And we need to take a high-level approach to trying to plan our workforce to support seniors across all sectors, because frankly, people move between those systems. And so I hope that when we're looking at workforce planning, we can work together across those systems in a more cohesive way.
Good.
There's a plug.
Anyone else?
I would like to add a few statements in regard to inspiring the younger generation to go and become healthcare aid and work in long-term care. Definitely, I think that is something that the educational society can do. So as an educational site, can implement a way to get the younger generation to want to go to long-term care. Even we have issues that I have noticed is we have students that, you know, go toward taking the healthcare aid program, and we know more graduate we have, the more they'll be able to help with the staff shortage. But what we're coming upon is that the experience and the site and certain site make the student not want to continue, which is of great concern to us. I have students that have gone to their first clinical placement and have decided that this is not for them, that they cannot do it. This is not what they taught the site. And lots has to do with the fact that, you know, with COVID and everything else, and the environment, the lack of positivity and welcoming to students, and the pressure that the student sees that the regular staff are going under, and them not willing to go that route, which is very concerning to us. So, yeah.
I wonder if I could just piggyback on that. One of the things we're not talking about, because it's difficult sometimes to talk about, in the urban areas of Alberta, about 17% of the care aid workforce is white. So we have a large, multiracial, multicultural, wonderfully diverse workforce. And we are not, I don't think, anywhere in the healthcare system really addressing, and Pat mentioned it, core issues of racism and sexism. So if we interview care aides, they will talk, if you can get them talking, about the dozens of microaggressions they experience a day, how a nurse or another provider will say, you know, you better toe the line here or you'll be deported, even if it's a lunatic statement. There's a lot of this stuff going on, and we can't have a healthy workforce in that kind of a toxic environment, even though if you walk into a home, you don't see it, you know, it's just never written on the whiteboard. So I think we've got to address that across our entire spectrum of health and social care, because if we don't, we will depend continuously over the next 10, 20, 30 years on immigrants to do the work that Canadians don't want to do.
Great, very appropriate comment. And for your information, one of the webinar AAG plan to do is in 2023 is diversity on senior care, both by the clients and as well as the workers. So hold in for that session, because that will be very interesting. Maybe this is time for me to sum up as a chair. First of all, I want to thank all of you, the presenters and discussants, for your very wonderful but very touching presentation. And as I said, although I know the topic very well, it is still make me feel about the emotions and the suggestions you made. And for sure, it make all of us feel that this is an important topic. We can together conquer and address, because if you don't fix workforce environment, you can't fix the continuing care problem. So it's very important. What AAG actually, when we started this webinar, we know it is a very complex issue and we cannot address it alone in one session. So together with the Alberta Gerontological Nurses Association, We are currently planning a follow-up think tank. It probably will be a day kind of think tank. And we are gearing it up at the winter of 2022. And in the think tank, we will, by the way, the notes for today's session will be in detail recorded as policy issues. And we will divide up the issues into different groups of experts as well as people that know the issue, care providers, clients, and we will have enough time to come out with solutions on those issues. And a position policy paper will be developed as recommendations. So I hope you will watch for that session. Of course, it will only go ahead if we can get funding available to host the session. But I'm very hopeful because it's such an important event. Regarding material in this session, we will put a recording and the slides in our website, AG website, about 2 weeks later. So if some of you want to go back and refresh your memory, you can check our website. Finally, you will receive a survey asking for your feedback. The survey has some suggestions on actions too in policy development area we should look at in workforce planning. So make sure you spend time to answer our survey because it will help us to thank for our think tank. So I want to thank you very much for attending. I want to thank you for putting all your questions in the Q&A and the chat box. And I want to tell you we are very grateful for your time and contribution and hope to see you again in our future session. So goodbye for now, everybody. Thank you. Thank you, the speakers.